Good morning and welcome to Veterans Heartbeat on the Pulse of the Veteran, where we discuss issues of health, happiness, opportunity, and well-being of interest to the veteran community, their families, and the community who honors them.
Good morning and welcome to another episode of Veterans Heartbeat, brought to you by River, the Rural Institute for Veterans Education and Research. My name is Jason Zencraft. My co-host Ed Lisofsky is here with me, and he is the Executive Director of River. We welcome you to a weekly wide-ranging discussion of issues, events, opportunities, and needs in our veteran community. Morning, Ed. How you doing?
Morning, Jason.
We'd also like to thank our sponsor, Farside Signs. They create amazing-looking vehicle graphics that will drive traffic to your business. They are located at 1526 South Avenue West in Missoula. Follow them on the web, Instagram, and Facebook, or just stop on by.
So, it's been a really happy holidays for a lot of us. We're getting a lot of snow over here in Missoula. And I want to kind of bring up, because I use Veterans Heartbeat as a tool to educate. We've talked a lot about the issues within the veterans community. And this morning, we're going to talk a little bit about pain and pain management. In the studio, we have Kristen Stratford, a social worker that works for the River program. And on the phone, we have Dr. Mark Ibsen and Dr. Frank Yearsick. Dr. Ibsen has been a ER physician for a number of years and semi-retired and has worked with pain patients for the last few years. Dr. Yearsick is chief of acupuncture for Cook County Hospitals. Dr. Ibsen, can you give us a little bit of your professional background to explain why you're competent to talk about pain management?
Thanks for asking me, Ed. I've been an emergency physician for about 35 years, treated pain really aggressively as an ER doctor, and then I became an accidental person involved in pain management. The people in my hometown of Helena were being abandoned by their family doctors as things changed and the pendulum swung regarding pain management. So people would come into my urgent care, and they were dropped by their pain doctor. And I wasn't treating chronic pain. I was treating withdrawal and acute pain and abandoned patients. But I did become really interested in it because I could see that none of my patients that were coming to me could find anyone else to treat them. So I studied it. I went to a bunch of conferences, found some mentors to help me with it. A lot of people say that there's not a lot of training in pain management in medical school, but that's kind of like saying there's not a lot of training in fever. Our education is more organ system based. So I learned a lot about pain when I did my cardiology rotation and chest pain and my thoracic surgery rotation with pneumothoraces and my surgical rotation with abdominal pain. So we know more about pain than we're letting on. A lot of my colleagues say they don't know anything about pain so that they can avoid doing it. So that's how I got started.
Well, I've read some studies, and one of the problems with pain management is money. There's not a lot of money available for doing real adequate care when it comes to pain management. Is that correct?
Well, it depends on what you mean by money, and it depends on what you mean by care.
Currently,
yeah,
the veterans are getting, it's taking 6 months or better sometimes for a veteran to get in to see a doctor.
Yeah.
And the doctors are overwhelmed over here in Missoula.
And in Helena too. Yeah, I think what has been discovered is that pain management at the veteran level has been. It used to be various vets would get their 360 oxycodone for the month in the mail, and they'd see their doctor every 3 or 6 months. And things have changed dramatically as people are watching access. Somehow people have decided that giving out too many pain pills has led to a heroin epidemic. And there may be some truth in that. But now veterans can't get the number of appointments required to manage their palliative care appropriately. It's difficult for them to get seen every month. Hydrocodone used to be Schedule 3, which allowed for some refills, and now it's Schedule 2. So the only non-Schedule 2 pain medicine available is codeine, or maybe tramadol, if you consider that a pain medicine. And it's hard to get into the doctor every month in the VA system. They don't have the capacity for it. And the other thing about managing pain is it depends on what the pain trigger is. Pain's a big wastebasket term, and there's people that have had 5 or 6 or 7 back surgeries, and they're not likely to get any more benefit from any more surgery. And they've tried meditation and acupuncture and stuff like that, and some of these folks have just run the gamut of the alternatives, and they have discovered that the only thing that works for them is their opiates.
Well, okay, now I'm reading from a study here, and I'm going to read parts of that, if that's okay.
Sure.
And I'd like your comment. Clinicians' role in chronic pain care is often a matter of guiding, coaching, and assisting patients with day-to-day self-management. But many health professionals lack training in how to perform this supportive role, and there's little reimbursement for doing so. Primary care is often the first stop for patients with pain, but primary care is organized in ways that rarely allow clinicians time to perform comprehensive pain management. What do you think of that statement?
Well, I think that is true, and that statement is kind of calling for a reassessment of how we do this. Pain is subjective. In the same way that anxiety or depression or other symptoms that patients present to the doctor, my job is to coach and help my patients come up with alternatives. And that's hard to do in 5 to 10 minutes. Some of my pain patients I spend an hour with now. And part of that hour is listening to them about how afraid they are and how anxious they are about losing access to their medication. So a lot of the time I'm spending with pain patients now just has to do with strategizing how to navigate this system, which doesn't seem to be interested in helping the pain patient at all.
Well, let's talk about the anxiety surrounding pain. As you said, it's a general waste term basket that describes a whole host of things. It could be cancer, it could be heart problems, it could be skeletal muscular. And we do know from statistics that over half of the veteran suicides are from chronic pain. One of the interesting articles that I read about the pain management is whether or not we agree with alcohol or we agree with marijuana or drugs in general, the war on marijuana has been lost by the DEA, with a number of states considering legalizing it or have it legal. And so a lot of these, the drug czar in the Obama administration was looking around for more work for their police officers, and they decided to go after a war on opiates. Have either one of you doctors heard about that?
Well, I can say that it's my theory that given that 30 states have some type of legalized access to marijuana, whether it's recreational or medical, one can no longer scapegoat marijuana for the heroin epidemic. It used to be, well, marijuana is the gateway to heroin, and of course that's never been true, but it was always blamed for that. Now it's really no longer viable to blame cannabis for the heroin epidemic, and so I can see that it has shifted to Percocet as the fault of the heroin epidemic. Like Johnny's the star quarterback of the football team. He breaks his collarbone. The doctor gives him some Percocet, which would be cruel if they didn't. Then 7 years later, Johnny dies of a heroin overdose, and someone thinks it's the fault of the Percocet. So I do see that happening kind of in a unacknowledged way. There isn't any particular proof about that, but if we're talking about evidence, there's no evidence that the increase in prescription opiate use in the last 15 years has caused the heroin epidemic. I think I have some other theories about that. So I think you're onto something there, Ed. I don't know how we would prove that, but it certainly is worth discussing openly instead of the unwritten way it's discussed these days.
Well, a lot of the listeners here, I feel are very good Christian people that don't believe in drugs at all, but yet a lot of the drugs that we do use are needed. I mean, it's like, can you imagine trying to treat an infection without antibiotics, but yet antibiotics have a very serious side effect if you're not careful on how to use them?
Yes, that's true for every pharmaceutical, which is why we have professionals trained in how to make a diagnosis, utilize the appropriate therapy for each diagnosis, whether it's surgical or medical. And then we have pharmacies and pharmaceutical companies to provide those complex systems to us. And I agree with you. If someone has high blood pressure and they're taking 4 high blood pressure medicines, they need to be monitored closely. And same with anybody on a handful of medications. That's why I like the alternative options much better, because the toxicity range is much lower. You can get good pain relief with a massage or an acupuncture treatment or a visit to the chiropractor. You're not putting yourself at risk for the damage done by a nonsteroidal anti-inflammatory that could have GI bleeding. I mean, the cousins of anti-inflammatories like ibuprofen and diclofenac, they cause just as many deaths as the opiates do. So, and nobody dies from acupuncture or a chiropractic visit or cannabis use. So I do think that the non-toxic alternatives, most people are going to be exploring those, and patients that we're talking to about have explored a lot of those options, I think.
Well, Dr. Yursik, you're the expert when it comes to the alternative treatments for pain. You were actually brought on to Cook County Hospitals as a gateway to get rid of prescribing so much. Can you describe your experiences there?
Yeah, I'd like to start with more of a contextual situation that I've seen out here in the Midwest. So we have the Midwest Pain Society, which is a subsidiary of the national organization, and we had a conference 2 years ago. In fact, I was presenting there on the use of acupuncture for pain, and that conference was really shocking at how widely accepted there was a crisis on opiate prescribing, and so much so that one of the presenters was a pharmacist who was getting his phone lines barraged by physicians asking for advice how to protect themselves from prosecution or being sued by their patients for overprescribing opiates. So it verged on hysteria, and I've never seen anything like it in a professional organization. So there's a behind-the-scenes kind of a Wizard of Oz kind of a situation where there's definitely reaction to and questioning the response to what's been bugled around the country by the media and by the FDA about this crisis and the heat it's putting on physicians and pharmacists. So that's still going on there. Now, in my battlefield, which is a battlefield of stabbing, gunshot wounds, beatings, cancer survivors, etc., to the tune of about 1 million patients a year, outpatients a year. You know, we made a decision, the hospital made a decision that they couldn't afford to bring people in, and they had a 300-bed hospital at one time, and I'm sorry, it was actually 3,000-bed hospital, and they could not care for county patients on other than an outpatient basis. So we have the walking wounded here, and they come in to the pain clinic. They've been turned off in terms of their meds that they've relied on because someone else somewhere along the line said, you can't prescribe those anymore to your patients, and they're coming for acupuncture, and they're telling me that they're going to the street for heroin because it's cheaper and it's more effective than the meds that they were on. So, again, just looking at two sides of the same equation. On one hand, we've got this heat coming down from the FDA. We've got pharmacists and physicians really not knowing how to proceed without keeping themselves safe. And on the other hand, the patient in severe pain who's turned to acupuncture because they can't afford procedures and their drugs have been taken away, and they are going out where they can find relief. So that's the real world out there. And we're just trying to sort through it by providing them with care that is not habit forming, is not damaging, that's been around for 5,000 years.
Now, Dr. Yursik and Dr. Ibsen are both involved with the Institute. We just had, without naming names, and I'm not going to even describe her too much, but a lady that has had MS for 11 years and progressively getting worse came into the Institute with a walker, and we've been doing some treatments at the Institute that are non-pharmaceutical, and she's walking without the walker. She came in this afternoon for her treatment, a different person. So there are alternatives.
Well, she had that bad headache as well, a migraine she's had for years that's caused her to have to rely on pain medication because it wiped her out. And that's where we in discussing the case, because I was in on the intake, agreed that let's take care of those things that are most acute, that are really interfering, and she's got a number of other problems, and the tendency is to try to do all of them. But in the process of clearing up her headache, doing some PTS points on her ear, those little things made a big difference in her MS symptoms.
Now, Dr. Ibsen, you had told me a while back about an interesting phenomenon that I didn't know about, and that is some people are like immune almost to opiates. Is that correct? Or, I mean, they can take a lot more than me.
Well, I was mystified when I started seeing patients that were on gigantic doses of opiates. And I just assumed, in fact, they came as a family. And I thought, well, this would be a great family business. Get the doctor to prescribe you enough opiates to put a city to sleep, and then you can go and sell them. And I kind of assumed that was what was going on. And then I started to wean these patients, and they began to die before my eyes. And I began to learn that there are variabilities in how much people metabolize or use opiates, just in the same way that there's, an easy keeper dog. I'm a dog musher, and there are some dogs that consume 3 times as much dog food as another dog in the pack. There are patients who require 4 blood pressure medicines instead of 1 to cover their blood pressure. And I'm sure even in the Chinese medicine realm, there's a big variability about how people respond to interventions that Dr. Yursik institutes. And so I did some research on it, and I found out that this is 30-year-old research, and that there's a system in the liver, the CYP450 system. That's as technical as I'll get about it, but that you could actually test people to see what their genetic predisposition is to how they would metabolize opiates or any other medication. And I think medicine's heading towards personalized medical care, and genetics is going to be part of that. So doing genetic profiles on some of these patients who had high dose requirements, they all uniformly had an ultra-rapid metabolizer enzyme defect that caused them to just chew right through the opiates. In fact, I had a couple of patients that were fired from their pain clinic because they could not measure any opiates in their bloodstream or urine. And these patients swore that they took their medications regularly. Their prescription drug registry indicated that they took them regularly. There was no evidence of them selling them. And when I tested them, they were ultra-rapid metabolizers. So naturally, they metabolize it so fast, it's no longer in their system. And they would get fired from their doctor thinking that they must be selling them. So the only evidence that someone is selling or diverting their pain pills is when they sell it to an undercover agent. All of these other things, these so-called red flags, are warning symptoms, just like there's red flags, like a black person might be more likely to suffer from sickle cell anemia. It's never heard of in the white population. So there's a red flag if someone has pain and blood cells that form a crescent. You know that, well, there's a red flag there for sickle cell disease. And we have to pay attention to population differences. And this has been completely ignored in this entire conversation about people who require opiates. And so people have put a unofficial limit on the amount of opiates patients can get because of some fear that is unfounded in the evidence, in the literature, some fear that if people get too much opiates, they're going to die. That's sort of like saying people are at high risk if they take 4 blood pressure medicines. They're more high risk for cardiac arrest than if they take 1 blood pressure medicine. Of course, they're sicker. And some chronic pain patients are really very sick and more likely to die because of that sickness, not necessarily because of the opiate doses that they take. It's a fascinating thing that if we all were attentive to it, we could actually relax a little bit about how much we're prescribing to people, because they really, with a good relationship with a physician who cares about them, it's pretty easy to figure out if they're doing well or not.
Well, that's fascinating. Dr. Yursik, real quick, you've been treating a lot of veterans with pain and everything else. Am I correct?
Yes, about 5,000 so far.
And you've been providing a lot of the protocols to the Institute for the treatments. Is that correct?
Yes, it is.
So both of you want to see pain management done, and currently the only way to do that on the standard of care with the VA in Montana is with prescription items. But I'm hearing that there's a lot of hope for the guys out there if they just reach out and start demanding some of these things. Is that correct?
Let me tell you what happened in Bethesda, and I just want to share this with the audience as much as with you, because I think you've heard the story. I went up to Bethesda on 2 rotations, excuse me, with 17 Marines who were amputees. Excuse me, and they were in such bad shape that they were going down to ICU because of the morphine they were on. And I went in there with John Howard, and we did the battlefield protocol, and watched these guys revived, watched these guys actually coming back from really severe opiate use to try to deal with the pain that was putting them at risk. Excuse me. So there are protocols, there are procedures that definitely can help someone naturally with no side effects that are going through a lot of pain. I use that same protocol. Actually, I used a different one. I used scalp here with 2 patients that had been recently had amputations, both full leg amputation with accidents, and watch them get up go from a 10 with pain, be able to navigate around the clinic on crutches with no pain. So there are ways to help patients in severe pain routinely with acupuncture. There are a number of protocols that can do that, and we just need to actually start shining more light on them, how they work, and doing some research, some evidence base, so it's not just anecdotal.
Well, I appreciate the work that you two have put into the Institute, and we're running out of time here this morning, but I wanted people to know that there is hope out there. And Dr. Ibsen, the things that you're doing on bringing the levels of pain meds down and getting them to where somebody like Dr. Yersick can work with them, fascinating.
Yeah, thank you, Ed.
Thank you, Ed.
Well, I appreciate everybody's listening to Veterans Heartbeat. And again, I go out to the people that are praying for our veterans. It's very important. Everything we can do, because it's going to be a battle this year. We're going to try and bring Montana. We have a goal, at least from number 1 to number 2. Thank you, everybody, and thank you for your prayers.
So thank you very much for listening to Veterans Heartbeat. We'd not be able to bring it to you without all the support of the listeners. And thank you again to Farside Signs for sponsoring the show. If you do need a unique vehicle design, swing on by and check them out. Also, thank you to our main sponsor, River. River has an array of services such as veterans-focused education, a vestibular disorder clinic, and now non-pharmaceutical treatments for pain, anxiety, and depression. Check them out on Facebook or on the web at riverofchange.org. Lastly, we'd like to show our appreciation to all of our veterans. Thank you for serving our country and keeping it safe.